I think we have quite a few people here tonight. Good evening. I'm Dr. Roa, brand new president of the ODA, and this is our first big meeting. So thank you all for being here. I want to welcome you to the town hall tonight. We have representatives here from the ADA. Thank you for your time. And we're also very thankful to Clackamas County Dental Society Executive, Dr. Fred Bremner, for initiating this idea. Next, I'd like to introduce the immediate past president of the Clackamas County, Dr. Jeremy Seuss, who will be our moderator for this evening. Thanks, Jeremy. I'll hand it over to you.
Thank you, Dr. Roa, and thank you for attending this evening's town hall. I look forward to the opportunity to hear from the ADA's leadership and to also have an opportunity to ask them questions. We will first have each panel member speak, and then we will have time for questions afterwards. So to the extent that you can, enter your questions in the chat, and we'll log those and then ask the appropriate panel member at the end. Please submit your questions through the Zoom chat. There will be time for back and forth, but that's the best way to gather all of our questions. I'd like to begin our program by introducing our panel, or at least the first member of our panel, Kathleen O'Loughlin, DMD, MPH, and Executive Director of the ADA. Dr. O'Loughlin is Executive Director of the ADA, the nation's leading advocate for oral health. She is a nationally recognized leader in healthcare, nonprofit, and education sectors, and she speaks around the country about the profession of dentistry, oral healthcare delivery, and public health policy. She was the first female dental school class president and valedictorian of Tufts University School of Dental Medicine, and is the first female executive director of the ADA, which was founded in 1859. Dr. O'Loughlin, I'd like to invite you to introduce our poll this morning, and then proceed with the poll reading and then your remarks.
You're going to have to help me out with the poll, but I can certainly set the stage for our conversation tonight. You know, I would say 2020, 2021 were extraordinary, unprecedented years. The impact on the profession globally was enormous. And I think all of us learned many lessons, discovered new skills, discovered new strengths, uncovered unknown weaknesses, and whatever trends were happening in dentistry, it certainly accelerated all of those trends for the good and the bad. So now, in terms of introducing the poll, I assume the audience is answering these, correct?
They are.
All right, so, and I see it on my screen. So the first question is, which of the following do you consider the most important topics facing Oregon dentists today? And I guess I could hum a tune while people fill it out, but I assume you'll be giving people a few minutes to answer.
Just let me know if you want me to stop it.
It'll be interesting to see the results, to see if there's consensus around what were the most important issues facing Oregon dentists over the last year. Well, while we're waiting for those results to be displayed, I can tell you at the national level, we heard from all over the country, and over the last week, this is interesting, third-party payers and workforce shortages. Of course, we are hearing about workforce shortages across the country, and our observation is twofold, actually threefold. So for the last 10 to 20 years, the dental profession has grown by about 30%. And that is due to the opening of over 20 new dental schools. So graduates of dental schools went from about 4,500 20 years ago to about 6,600 today. And during that period of time, dental assisting programs and dental hygiene programs only grew by about 10%. So if we had been watching workforce capacity carefully over the last decade and a half, we might have been tipped off that eventually we would have a disparity between allied team members and dentists. I think COVID accelerated that. And I'll explain why. We know that about 7% of hygienists did not return to their clinical settings for many reasons: childcare, parental care, fear of contracting COVID, not quite sure of the safety of vaccines, or in fact, many health professionals have rejected the safety of vaccines and they are yet to be vaccinated. We also know that the shutdown for about 2 months back in March and April and May of 2020, many staff were furloughed and chose to seek other careers, alternative careers, during the COVID pandemic shutdown in many states. And so for all those reasons, we are now exacerbating a shortage of hygienists and dental assistants across the country. So what is the ADA going to do about it? I can tell you we meet with the House of Delegates in 2 weeks in Las Vegas. One of the resolutions that has come in that will be discussed and debated on the floor of the House is what can the ADA do to mitigate the risk of not having sufficient capacity around dental team members, which could lead to restricted practice hours or lower patient volumes just at a time when patients are coming back to the practice. About 95% of the public that we poll is ready to come back for full treatment. So we are concerned about that, and hopefully we'll come up with some good strategies to encourage the states to look at workforce capacity and work with their community colleges and their, the high schools that gear students towards career choices, the vocational type high schools, so that we can maintain a sufficient supply of allied team members. And I think the other issue is third-party carriers. Gosh, I've been a dentist for 40 years, and my relationship with the dental benefit companies was always a point of stress in my practice, despite the fact that I was on a Delta Dental board at a time when the Deltas seemed a little bit more friendly towards the profession and easier to work with. And then I think the industry started aging and not modernizing, and the stress on the dentists became acute because the practices would feel the fee reductions, the stabilization of fees far below their acceptable levels, and the write-offs have continued to escalate across all modes of dental practice. So, it used to be 5% was the amount of write-off. Now it could be closer to 20 to 25% or even higher in some programs. So dental practices are extremely stressed regarding the equitable treatment by third-party carriers. And we know that. We get 6,000 calls a year trying to help dentists navigate their relationship with third-party carriers. A couple of things we've observed. One, sometimes dentists don't read their contracts and they go ahead and sign them. By the time we see them, there's nothing we can do other than to say, you signed the contract, you agreed to these things, how can we help you mitigate the issues or even drop out of that network? And at that point, many dentists are fearful that their patients will leave their practice and go to another practice that accepts benefits. So dentists feel trapped. The administrative burden has gotten much worse. We know that utilization review and management has gotten much higher attention by dental third-party payers because they are squeezed as well by the benefit managers who purchase the programs, who don't want to pay more for a prepaid dental benefit and yet want more service and more patient satisfaction for their beneficiaries. So for all these reasons, we have entered a period of time where our state public affairs group, and Mike Graham is on this call, created a program they call FIST. And the signal is this, right? You put your fist up and it's fighting insurance interference. Mike, you're going to have to help me out with the S and the T. So we have dedicated staff working with your state public affairs people to look at a legislative solution to level the playing field. We are making great progress. I can't give you the exact number of bills that have been passed, but I feel like it's in the 60s across different states that essentially, start to create some equity in the third-party payer dental practice doctor relationship. And so let's, do we have another question? And then I'm going to turn it over to some of my colleagues. Mike, could you comment on the state public affairs program and the dollars dedicated towards this?
So I'll actually get into this a little bit, Dr. O'Loughlin, but FIST stands for, you were very close, Fight Insurer Interference Strategic Task Force. But all you need to do is this, and we know what you mean. And the FIST is run a little bit like the SPA program, the State Public Affairs Program. And for those that don't really know, the State Public Affairs Program was set up a number of years ago to assist the states, not just with money, but also with expertise. And so my team in Chicago in state government affairs has become very expert on the issues that the states are facing. And so they're able to assist every state that asks for assistance by letting them know what's happening in the other states, what are the model programs, and again, money is also doled out to help lobby issues and also public affairs issues. Now, the FIST program was set up almost to run parallel with the SPA program with a real emphasis on the third-party payer issue. And I'll get into that a little bit, Dr. O'Loughlin, the details when I'm speaking about the success of the FIST program.
Great. So Jeremy, do you have another polling question for the audience?
I don't think so. That was just an intro poll that we had. We're going to proceed through the speakers. Dr. O'Loughlin, it's come to my attention that you have plans to retire. Is that correct?
Yes.
Congratulations. I was listening to another webinar, and Dr. Klemmedson spoke very highly of you. Some of the notable achievements were your huge contributions in accountability and policy, managing 400 plus staff, achieving an even budget, publishing department that was, quote, stellar, and then the Science and Research Institute, the new rising star of the ADA. So thank you for your service, and congratulations on all of your accomplishments over these years.
Well, thank you. It's been a great run, and it's nice to leave on a high note with the ADA in good shape, and coming out of COVID, it's even sweeter.
Thank you. Now we'll introduce Mike Graham, the Senior Vice President of Government and Public Affairs. Mike Graham has fought on Capitol Hill for issues important to organized dentistry for 25 years. He served in various positions in the ADA's Washington office. Currently, he is ADA's Senior Vice President of Government and Public Affairs, representing over 163,000 ADA dentist members. In total, he has 40 years of government affairs experience in the federal and state legislative arenas. He has represented 2 other associations, served as a gubernatorial appointee for 2 Maryland governors, and worked for a U.S. Senator from Maryland, a Maryland congressman, a Maryland state representative. Mike has a master's degree in public policy from the University of Maryland, Baltimore County, and a BA from the Catholic University of America. Mike retired as a commander in the United States Navy following his service in Iraq. Mike, thanks for being with us. Take it away.
Thank you, Doctor. And Margie, if you could bring up my slides, I'd appreciate that. You know, when I started preparing for this, I thought to myself, wow, this is a whole lot of information. And I kept trying to pare it down, and then I realized I really need to do slides to give you an idea of what we, your advocates in Washington, D.C., and as Dr. O'Loughlin alluded to, assisting the states through the SPA program and the FIST program, what we try to do on the state level. So, Margie, if you could go to the first slide. Let me just start off by saying that the poll issues actually, except for the workforce issue, which is a relatively new issue to us, and we look forward to getting into when we get to SmileCon. But the issues align pretty much with what we've been trying to do in the Government Affairs Office, and in listening to what the dentists want, the problems that they're having, and then we address those. And so I put the FIST program up here first because I would say that's probably our #1 issue is the third-party payer issues. And I've tried to keep my bullets short with just the results. So FIST actually began about 3 years ago, but in this year alone, 95 legislative proposals were introduced in 33 states. And those legislative proposals have to do with dental insurance reform. And you'll see at the third bullet, just a few of the issues that we're lobbying. There are actually 34 issues that we've identified that are a problem for dental practices that stem from the insurance companies. But so the great news is 95 legislative proposals were introduced this year in 33 states, and 26 of those 95 passed into law. They became law. Now, for those of you who are baseball fans, that's about a .274 batting average, which is pretty darn good. Won't get us in the Hall of Fame, but we're working toward that. As the next bullet points out, the 95 dental insurance reform legislative proposals that were introduced was an increase of 50% over 2020. So we are really ramping up our legislative effort on these insurance reform issues. And actually, we had tremendous success this year in 2021. We thought we were successful in 2020 in getting 11 bills passed, but when we passed 26 this year, and this year's not over, we still have a chance to pass a couple more. We are going like this. We are trending upward on this, and we're getting smarter in fighting the insurance companies every day. So next slide, please, Margie. Dental therapists. Now, I know this is an issue that you faced in Oregon, and there's been about 20 states that we've been operating in over the years, fighting the dental therapist issue. And if you ask, are we successful in that fight? The bottom line is that there are only 5 states where there are dental therapists operating. I'm counting Alaska as one of those states because they're actually dental health aid therapists, or DHATs. But Minnesota has the vast majority of dental therapists, around 100. And it's been 100 for a few years now. And that's in part because Pew and Kellogg have put a tremendous amount of money into Minnesota. There were the 2 schools that started out training dental therapists. But beyond Minnesota, you've really got very few. You've got 1 operating in Maine and 1 operating in Washington State. And I'll let you correct me, but I believe you had a demonstration project going in Oregon. I don't know if you still have any dental therapists there, but I know legislation recently passed, if I'm not mistaken. But this has not really taken off. The dental therapist movement has not taken off. And I refer to it here as an organic movement. And so I'll tell you, our friends at Pew and Kellogg have dumped tens of millions of dollars into this program. And in my opinion, they have very little to show for it. And as you can see from the last bullet, there's only 1 code accredited program, and that's up in Alaska. So I think we've done a pretty good job in educating legislators about what we think whether or not dental therapists have value. Next slide, please. And I see, by the way, there are some questions coming in the chat. Well, I think we can address those. Maybe Dr. O'Loughlin, who's terrific at fielding these kinds of questions, can help me do that. Medicaid. We have been focused on trying to reform Medicaid for years, and it's very hard because when we approach the states say, well, this is a federal program. And when we approach the feds to fix Medicaid, they go, well, really, it's a state program. I just had that conversation tonight with Senator Hoeven from North Dakota, where we had this conversation about Medicaid. But currently, we're fighting for adult Medicaid benefits in about 10 states. And the good news about Medicaid is that we have seen tremendous progress in treating kids. And as you see here in the slide, in some of these states, the percentage of kids who are Medicaid kids are actually receiving care in some states at the same or close to the same rate that kids under commercial plans are receiving it. But I think the crowning achievement this year is that Medicaid reimbursement increased in 14 states this year. That's pretty good. And we've seen that go up in about half the states over the last 3 years. And I'll say it's not enough. And we know that because these reimbursement rates in some states are so low that we need to keep working to get that number up. And we're going to continue to do that. Next slide, please. All right, COVID. I know it's a nightmare that we're bringing up, but it's actually a good story, I think, for dentistry. The dentists really came through and helping us lobby Congress to get what you needed to keep your practices afloat, keep them going once your governors allowed you to open your practice back up. And a big part of that were these PPP loans and the EIDL loans. I think everybody had multiple shots at getting money through PPP and EIDL, and I hope you took advantage of that. One of the biggest successes I think we had was convincing FEMA, a federal agency that had control over the PPE rather in the country, to put dentistry on. We were not on the priority list for FEMA. We got on the priority list for FEMA, and we moved up to number 4 on that priority list. And they gave us 4.5 million KN95 masks and 1.8 million gowns, which we distributed all of that to dentists across all 50 states. And I think that was a tremendous success. And then we worked very hard with HHS, and I have to say HHS was really terrific to work with regard to the provider relief funding for dentists, and that's affiliated beyond those public programs of Medicare and Medicaid. So that was a tremendous success as well. And you'll see in the last bullet point, we worked hard to make sure that those the dental offices, the protocols stayed the same during COVID. So a lot of successes in COVID. I could name a dozen or 2 dozen more, but those are, I think, the highlights. Next slide, please, Margie. Okay, now this is a battle that I'm engaged in right now, and our staff, and I hope you are too. It reminds me of the COVID experience where we need dentists all across the country to write their members of Congress and get involved in this from a grassroots standpoint. But without a doubt, the ADA is taking a lead of all the dental organizations on Capitol Hill to promote our policy, and that's to focus on low-income seniors and not to provide a dental benefit for all Medicare beneficiaries and to put it in Part B. And I'm not going to get into Medicare Part B. It's complicated, but it was set up for the physicians and it's unworkable for the dentist. So as of last Friday, we had over 50,000 emails going into congressional offices. And anecdotally, I hear from members of Congress who say, oh yeah, I'm hearing from the dentist. So in some congressional districts, they are getting a lot of emails from their dentists, but I think in some offices they're not getting as many as we'd like. So we need to keep pushing that because we're not done in this Medicare dental benefit fight. We have a long way to go. Having said that, I think we've been in every major newspaper across the country. Just recently, as in yesterday morning, the Wall Street Journal wrote an unfortunate headline, but the guts of the article was, I think, very good in laying out ADA's position and how it's different from some other organizations that are fighting for a Medicare dental benefit for all that. And the way they're doing it wouldn't work for dentistry. And we're making our case. And I think we're able to hold our heads up high in this debate because of the position that we're taking. And we continue to meet every day, either face-to-face, because we're doing that, face-to-face on Capitol Hill, or through these Zoom meetings. And we're getting our dentists and many of these key House and Senate members, we're getting those meetings with our dentists and those members. So stay tuned, but stay alert. We need to keep working on this issue. It's not by any means over. Next slide, Margie. I'm going to reach back a few years and just to remind you that you know, there was a significant federal tax reform in 2017, and we had your dental practices in mind. And I won't go through the bullet points here, but a number of these help dental practices significantly. The cash accounting provision, the Section 179, and then if your business is a pass through, then you would have been helped by the things that we worked on and succeeded with in that federal tax reform bill in 2017. Next slide, please. All right, McCarran-Ferguson, I actually saw this. You know, whoever wrote that question, you're exactly right. We fought to pass McCarran-Ferguson. It took us 12 years to do it. So what, right? So what? It passed. That's great. We beat the insurance companies, but so what? Well, I'll tell you, what we're trying to do is we're trying to work with the Department of Justice, the FTC, to uncover the possible insurance antitrust violations that may go on. And this has sent some significant reverberations through the insurance, the dental insurance or dental plans companies. And we hope that we're going to see at some point some litigation from this. And, you know, that's what I think the Department of Justice has indicated in a very public way. When McCarran-Ferguson passed, they said, you know, we'll be able to investigate some of these insurance companies. So stay tuned. It's been less than a year, but we've already seen some activity in this area, and the insurance companies are trying to be on their best behavior, I think. Next slide. You know, Give Kids a Smile is, and I was involved in it because I've been representing dentistry for almost 27 years now from the get-go. And it was a program that basically highlighted what a lot of dentists had been doing for years, and that's providing free or discounted care to individuals who maybe couldn't afford it. And so Give Kids a Smile has been a terrific signature program, and it's we've used it to tell our story on Capitol Hill, and I know the states have used it as well. And we're about to launch a program directed toward veterans, and it mimics the Give Kids a Smile program. So I think it's a terrific program that involves the profession and tells our story, which needs to be told about all the things that we're doing for folks that are not fortunate enough to be able to pay for their oral health needs. And we always say charity is not the answer, but it's so much appreciated, I know, by the people that receive the care that you provide. And I think that's it, Margie, and maybe we can take some questions.
Mike, that was fantastic. We're a little bit ahead of schedule. One thing that you had one slide about, and I was a little bit surprised. I've heard you talk for an hour in terms of Part B and how it's different from Part A. And I know we don't want to put everybody to sleep. It's been a long day, and it's getting a little bit dark over here at least. But it really opened my eyes into what's the difference between Part A. What are some of the pitfalls of Part B? How are dentists and hospitals set up so very differently to access those benefits, to just, you know, to receive the codes, to the use of diagnosis codes, to what the EOBs look like and our ability to read those, let alone the fact that our practice management software by and large is just not set up to be able to deal with or access these benefits at all. We may have some oral surgeons on the line, and I think they'd probably share, you know, in those frustrations. Do you mind giving maybe just a 5-minute version of why Part B would be exceptionally difficult for dentists to access, and maybe even a teaser of what I've heard described as Part T. What would a better solution look like?
Well, I'll tell you what, the person who's probably better than I am to talk about this would be Dr. Klemmedson, who's an oral surgeon. Even Dr. O'Loughlin knows so much more about this, but I will give the teaser and then maybe turn it over to them. You know, we're actually very fortunate to have on ADA staff a woman, Krishna Aravamudan, who knows the Medicare issue better than I would say, or at least as well as everybody on Capitol Hill that we've talked to. And she actually can go toe to toe with the experts on the Senate Finance Committee and the Ways and Means Committee in explaining how Part B that was set up for the physicians in the Medicare program just does not work for the dentist because we're different. And our coding is different. And, you know, Kathy brought up the other day that, you know, you can pick up the phone and you can talk to an insurance company, a dental plan company. You can't do that with Medicare. Everything's got to be electronic. You know, in the bill that's up there on the House side right now and being debated, maybe soon to come to the House floor, that it's delayed by 6 years, meaning there will be no dental benefit given if it were to pass for 6 years. And it's because they're trying to take the square foot peg and put it in the round hole, and they're trying to make Part B work for dentistry, and it just doesn't work. And so that's the reason why we're talking about creating a whole new part in Medicare. And they did this for the drug companies when they created Part D. And we think the same thing needs to happen with dentistry if they're going to do this Medicare dental benefit, because we could set it up in a way that at least the program would not be onerous for dental practices to have to work with. And maybe I could turn to Dr. Klemmedson real quickly and then
Sure.
Dr. O'Loughlin just to chat about his experience working with the Medicare program.
Sure, and I'm perfectly happy to step in, and let me just kind of introduce myself, so Jeremy doesn't have to do that in a little bit. My name's Dan Klemmedson. For the next 18 days, I'm still president of the American Dental Association. I'm from Tucson, Arizona. I'm an oral and maxillofacial surgeon. I have a dental degree. I have a medical degree. I'm a Medicare recipient, and I'm a Medicare provider. But I'm just like you. I work in the office. I'm going to go back. I'm right now in Nashville, Tennessee at the oral surgery meeting with one of your colleagues, David Howerton. And I'm going to go back on Monday, and I'm going to be working in the office just like everybody else. And so I have all the same questions you do, and I have to deal with all the same questions that you do. Medicare was developed in 1965, and for those of you who don't know, when it arose, the physicians fought it and the dentists fought it. For some reason, we got left out. But it was fee for service, and it was fee for service for probably the first 15 to 20 years. There was nothing that stopped anybody from raising their fees as necessary. It was the perfect market-based economy and situation. It's exactly what we wanted and what we liked. But it didn't solve the problem of people not being able to afford what physicians were doing. The costs kept escalating, and as expected, the government said, hey, we can't keep paying for this. And that's when they developed DRGs, and that's when they developed these complex coding systems that involve the diagnostic codes, which in dentistry we don't use and we're not required to report. If we were to get into Medicare Part B, we would have to report diagnostic codes, ICD codes, which exist for some dental disease, but not with the specificity that we would like. And in addition, their fees are set by a system called RBRVS, which is a relative value scale. And they did that because they needed to figure out a way to set fees. And so say they set a baseline fee for something that is relatively common, like a routine clinical exam, and then they downcode for things that are less hard, and they make things harder for others. And they figure out what's the malpractice relationship to that, what are the practice expenses related to that, and what's the doctor's time worth. And they set these codes up for everything, and then they apply. Then there's a multiplying factor put on every year, which is dependent upon the pool with which you can generate revenue. And on the physician side, there's a thing called it's a neutral benefit. In other words, they can't exceed this big giant pie of revenue. And so for some reason, the dermatologists need more than the surgeons, and they increase the codes for the dermatologists, it gets decreased for the surgeons. So it's a very complex situation which doesn't exist in dentistry. And so should we get into Part B, we would have to figure out how we get these RBS values for all the procedures we do. And there's over 700 procedures we do. And the bigger question is, how do we factor in different materials? Because there's different materials for crowns and all these other appliances that we build. How do we factor in the fact that in reality, we are all our own little mini surgical centers? How do we factor in the increased cost for everything that we do that many physicians don't have to do? And so it's in reality a brand new system in dentistry. In Medicare Part B, if you are a non-participant, you can't balance bill. Nobody can balance bill. And so just opting out doesn't answer the question. As a dentist, if you opt out, or a physician, if I opt out entirely, I can still treat patients if they agree with me to sign a contract that says I can bill them what my fee is, but they're forbidden from billing Medicare themselves. And so you have to have patients that are willing to go that direction. And a lot of our patients above 65 say, hey, I just as soon take advantage of my benefits, just like you and I do. I imagine there's probably somebody on this call that is of Medicare age like me. Well, I would very simply ask, do you go to a Medicare provider or do you pay for fee for service? Well, most of our patients are like that as well. And so our problem at the ADA, given the fact that we have a Senate and a House and an executive branch that could theoretically pass this and just tell us what they're going to give us, we're trying to shape something that potentially has the potential to work for us. And so we're trying, our Part T is something that's much closer to what most dental benefits that we're used to. And that's the direction we're trying to go in, with the caveat that at least under the $3.5 trillion that's in this bill to start with, there's not even enough money to develop the benefit that the Council on Dental Benefit Procedures 2 years ago said would be necessary to provide the care that we would deem reasonable for the majority of dentists. And so this is phenomenally complex. There are many who would like to say, no, no, hell no. And there are many who would like to say, hey, we should sign on and everybody deserves this benefit. But when push comes to shove, if we can't design a plan that works for the vast majority of us, no one will get care. And so those are just some of the difficulties that we'll face with this, whatever direction it goes in. But we're trying to shape it to go in a direction that we're much more likely to be able to work with.
Jeremy, let me make one additional point to what Dr. Klemmedson said. CMS is having a difficult time figuring this out. while Congress is debating how to pay for it and what benefits would be covered. This could be an opportunity to reinvent dental benefits in a brand new way that it makes it successful for the patient and makes it successful for the practitioner. I think I'm monitoring the chat room, and a lot of attendees are complaining about the things we're well aware of. Waiting for wait periods to expire, where reimbursement levels are set, the amount of utilization management that a practice could be subject to. And I think it's important to understand that Medicare could be an opportunity to go through their CMS innovation group and really put a task force together with lots of stakeholders that care deeply about this issue and come up with something new and creative. Because I think I would agree with most of you in the meeting tonight, the current dental benefit programs that are out in the commercial space are old and not helpful at this point in time. I think back in the 60s when the Deltas rolled out, the first time ever dental prepaid benefit, it was a wonder. And utilization shot up by almost 50% in terms of patients accessing care. And now we're seeing that even young adults who have a dental prepaid benefit are not accessing care for all kinds of reasons related to the generational divide. So it's time for something new, creative, and this could be an opportunity to start that discussion. I think before we leave the dental benefit discussion, I know Mike saw the question about McCarran-Ferguson. McCarran-Ferguson will empower the Federal Trade Commission to police the antitrust issues that have dogged this industry and the profession for years. It won't have a big impact on the day-to-day practice of practicing dentists. And in terms of how benefit programs are sold, I spent a bit of my time in the dental benefit industry. Purchasers of the benefit make enormous decisions on behalf of the beneficiaries. And we have to crack that market in terms of helping dental benefit managers and health benefit managers in companies understand the value of a good dental benefit and what that looks like. And one idea I'm going to leave you with is to Google Bento or go into the ADA website and check out Bento. It's an alternative market disruptor to traditional dental benefit plans. You can use it as a dental benefit program, as the ADA will be doing soon for its own employees, or you could use it to support your own in-office plan, which gives your patients an alternative mechanism to afford dental care. So stay tuned. There's lots of activity in the third-party market, and but please feel free to reach out to us if you have issues and questions, and we can help you. Thanks.
Thank you. Could we get Dr. Klemmetson's slide deck put up? I think he'll go through that quickly, and then after that, we'll open it up in a town hall format and address all the questions that we see building up in the chat. And please continue to add your questions just as we arrive at each topic. The speaker may address it during their speech, or we might just circle back and get those at the town hall. Thank you.
Yeah, and thank you, Jeremy. After a year of doing this, you get to the point where you recognize that most of the people listening have questions that are more valuable to answer than most of the stuff that we can provide on slides. So I'm going to run through this real fast because I've been monitoring the chat as well, and I just as soon like to address some of those questions. Next slide, please. So, in the last year, we've done a lot of stuff. So clearly, you know what we did relative to small business relief regarding COVID. Mike just told you about ADA advocacy and the OSHA regulations. Somebody mentioned workforce trends, and I'll talk about that just briefly. I don't know you, but my mental health has been a little bit weird in the last year and a half. Maybe it's because I've been involved with ADA's leadership. Maybe it's just because we've all been stressed because of COVID. You heard about insurance reform and advocacy. I can talk about that a little bit more. Diversity and inclusion is phenomenally important. And then there's some other issues I'll run through real quick. Next slide. I'm assuming many of you have taken advantage of the PPP loans the idle loans, the provider relief funds, and the employee retention tax credits, let it be said that these were incredibly valuable for all of us. I'm not sure how we were able to get the inside scoop on most of this and get the smart accountants and money managers to help us through that, but they did it. Most of us benefited from it. Suffice it to say that the ADA is still pushing as hard as we can to make sure that these benefits are not taxable and are forgivable. And if you have issues regarding any of this, make sure you call us at the ADA and we'll see if we can't help you out with getting that done. I certainly utilized parts of this, and it was an absolute benefit. I always kind of wonder where the hell they come up with all this money, but I'm just glad they did. Next slide. So somebody mentioned workforce. Okay, everybody is having problems looking for employees, assistants and hygienists. It's throughout the nation. Oregon is a little bit higher in need than the US in general. But I've been in Montana recently, North Dakota, Mississippi, Alabama, Rhode Island. Everybody's having the same problem. I think Dr. O'Loughlin discussed it briefly. There's multiple reasons why. I think it's something that we as a profession need to figure out a way to address. But when you have 50 states and 2 territories, sometimes it's difficult to get things done. It's probably a pipeline issue as well. And we're just gonna have to work on it at a state level. Our Health Policy Institute is certainly looking at this stuff, trying to get us data so that we can figure out directions that we can go more effectively. Next slide. And these are the same. This is just another slide talking about challenges. Some states are having bigger issues than others. Major challenge in Oregon as nationally. Next slide. Top reasons for not working, pandemic not under control. I'm worried that my employer's not following the rules. I can't get childcare. That's a big problem in my office. And a lot of people, including dentists, are using this as an excuse to retire. I'm still here. I still got a few more years to go, although I'm now an employee dentist, so I can see the light at the end of the tunnel. But there are multiple reasons, and sometimes it doesn't take much. Next slide. We've done some studies. We did a study actually with the Hygiene Association, and prevalence of COVID-19 among dentists and hygienists is relatively low, and it's less than other healthcare providers. That means what we do it well. We've learned probably well back into the 80s when the HIV/AIDS crisis came around. At that point in time, the big issue was, do you mean we're going to have to sterilize handpieces? Well, nowadays that is pretty routine stuff, but that just goes to show you the progress we've made. I think we've weathered this phenomenally well, and that's why OSHA left us alone. In 2000 or in the 1980s, if we hadn't had a very important dentist congressman from Georgia, we'd have been toast relative to OSHA, but he saved our souls. And although most of us consider it onerous, it could have been much worse. And that's the value. That is totally the value of being involved in organized dentistry and participating in the political process. Next slide. Next slide. There we go. Yeah, we were exempt. We got it pretty easy. There are very few things changed for us. That was the best news I received. I remember talking to the White House or to somebody in OSHA about that. We gave them all the information that we had, and we prayed that they wouldn't create bigger issues for us. And so we escaped that regulation. And so let's move on. Next slide. Insurance companies, you know, that's been in the chat. I began my career at the ADA as a member of the Council on Dental Benefit Programs. I did nothing but work from that time on to figure out all these issues: assignment of benefits, denials, non-covered benefits. We had, at that point in time, all the CDT codes were created and decided by a group of 6 dentists and 6 insurance people. You had to have a majority to win. A tie was a loss. I know you can imagine what the majority of the votes were. It was brutal. We are out of that system now. We can create the codes we need. But the insurance companies are a unique animal. Many dentists say, hey, why can't we just work in the free market economy? Well, we do work in the free market economy. The problem is the free market is between the seller of a dental benefit and the purchaser of a dental benefit, which is, in the most cases is an employer. Your patient and you are not in the equation. And unless somebody is totally fee-for-service and has no insurance, which is the purest pure market, we are in a adulterated pure market. And so despite the fact we proclaim we want a free market, we are actually in a free market. We're just on the side. And that's a situation that we all, as benefits providers for our own employees, play in that game as well. And so it's phenomenally difficult. I'm hoping that when the ADA gets our registry up and running, we will get the data that we need to show what the cost of providing care truly is, so that we have truth behind what we say when we say, hey, this is what we need to get paid to provide this service, and we have data to back it up. Right now, the only people who have data are the insurance companies, and that data is claims data, and claims data is phenomenally invalid relative to outcomes. And so we as a profession need to get better at getting the data. Facebook knows more about you than you do. Google knows more about me than I do. We should know more about the practice of dentistry than the insurance providers. And if we get to that point, we'll be able to have some influence over our reimbursement. But until that point, it's kind of a he said, she said deal, as Dr. O'Loughlin knows, having been on that side of the fence. Next slide. Rest and recharge. You know, most people in Oregon are pretty good about rest and recharge is my sense of it. When I get to Oregon, I think about Deschutes Black Butte Porter. And I'm sure you understand that. And so I think you are all pretty good at mental health, physical health, and wellness. But it's critically important. COVID has totally created a major strain on our profession, the medical profession, and almost everybody. If you have issues, the ADA is there to help you out. We recognize it. We're working on additional programs to help, but it's critically important that you're aware of that. Next slide. And this is probably one of the most important things I can talk about. I'm an old guy. I'm an old white guy. I graduated in 1980. At that point in time, we had a very homogeneous dental profession. Right now, over 51% of the graduating class are female. There's a significantly increased proportion of ethnically diverse and racially diverse graduates. Our future is different than what our current leadership and current membership looks like. We need to engage. We need to make sure that those who take our place have the ability to do so in a way that works for them. And that may mean different practice modalities, you name it, all sorts of things. It's hard for organizations as old as ours to change, but it's something that we have to do. It has to begin at the level with which you exist, at the constituent and state level. And so there's nothing more important than young career dentists from getting actively involved at an early level and make a difference, because you need to push us along as much as we need to pull you along and let you know what has worked well for us. Next slide. ADA, Science and Research Institute. We've always had science at the ADA. We are evidence-based. It's critically important. It's the basis on which we work. We recently combined the science that was conducted at Volpe, which is the National Institute of Science and Technology. We are the only organization on that campus, but we've combined it all into one institute. Dr. Raymond Comilla, who is going to be our new ED, has chaired that. He's the former dean at the University of Oklahoma College of Dentistry. Big on research, is changing that around with Dr. Arujo at the ADA. Science is our future. It is doing some phenomenal things, and it's going to push us forward. I already talked about the clinical data registry, and I kind of mentioned health equity. You know, it's been a tough year for the United States in a variety of reasons. We've had social injustice. We've had George Floyd. We've had Asian violence. We've had an insurrection or some violence at the Capitol. We've had some AdPAC issues regarding political contributions. It's been a rather interesting year, nothing of which I anticipated, but that's the real world. You know, we have to face that. Dentistry exists not in a swim lane, but in a swimming pool. Our patients live in a land that's much further outside the swim lane than you would imagine. And we have to engage them in all areas of their lives if we truly want to achieve what our constitutional duty, our mission and our vision state, which is achieving optimal health for all. And so it's a difficult deal. We're trying to make that change and make that adjustment, but it's difficult to turn a big ship around. Next slide. And I think I'm done. So I went through that as fast as I could. You've had some phenomenal questions on the chat, and I'm going to turn this back to Jeremy, and maybe we can answer some of those questions on the chat.
Thank you, Dr. Klemmedson. Appreciate you being here tonight. Dr. Calie Roa, would you like to make a few remarks before we open up a town hall style question and answer?
There you go. I'll unmute myself first. Thanks, Jeremy. So basically, I wanted to share where we were from the Oregon perspective and what we've been doing here locally in our state. You know, just like the ADA advocacy work is centered around our members. We have a great team of staff and contractors who guide and implement our work, but our ODA members are critical to their success. The work we do is for our members and by our members, and our advocacy work begins in campaigns, moves to the legislative process, and continues during bill implementation through regulatory work all year long. Our team sifts and sorts 300 to 400 bills and works proactively to defend against policies that would impact our patients and practices. ODA advocates for dentists every step of the way and in every conversation we can. In 2019, we had success implementing legislation that now allows dentists to administer vaccines. Through this, we've become a model state with others, seeking our support in implementing their own legislation. In 2021, we introduced a package of bills with ambitious policies, aiming to increase Medicaid reimbursement rates, implement scholarships for tribal members, and create a new provider incentive program for new dentist graduates serving Medicaid patients. Still have a lot of work to do, but our commitment to the profession and our patients remains our focus. We've worked with dental partners on scoop and fill scope expansion, narrowed new data reporting requirements, worked to streamline insurance processing. We got the acceptance of the Glosky and did away with live patient exams. And we continue to support efforts to increase liability protection for providers who had to alter their standard of care due to COVID-19 precautions out of their control. Our team at the office spent hundreds of hours negotiating on dental therapy licensure, ensuring that the final product included rigorous education standards, increased supervision requirements, and limited the scope. ODA, collaborating with our DCO partners, also helped to secure $19 million to restore Medicaid dental rates for the remainder of the year. This was in response to OHA cutting reimbursement levels to the lowest we've seen since 2014. ODA spent a great deal of time collaborating with other regulatory bodies, such as the Oregon Board of Dentistry, the Oregon Health Authority, and Oregon OSHA through our Regulatory Affairs Council. This keeps us on the pulse of what's happening in our state so we can be proactively working with these entities for the betterment of our providers. Since the pandemic, ODA has spent more time interacting with OSHA than ever before. We successfully defeated a requirement which would have made us use airborne infection isolation rooms, also known as negative pressure isolation rooms, for any aerosol generating procedures. We would have essentially shut down dentistry in Oregon. We also successfully ensured that most dental offices were excluded from new employee paid leave requirements. What's more, ODA successfully lobbied for N95 respirator requirements to align with CDC requirements. We make sure we're at every board meeting held by the Oregon Board of Dentistry and have a seat at the table, especially in regards to the new rulemaking being created for dental therapists in our state. We're striving to make sure the implementation of the hotly contested legislation is done in a fair and equitable way, staying within the legislative intent. Within our member dues, ODA members fund the Dentist of Oregon Political Action Committee, known as DOPAC. These funds are used to support political candidates who support dentistry. The funds are used to build relationships with candidates who become lawmakers. ODA members are engaged at every step along the way, from the DOPAC board approving the contributions to individual members engaging in the actual check delivery. DOPAC contributions afford ODA members a critical seat at the political table. DOPAC is recognized as being one of the largest and thereby one of the most influential healthcare PACs in the state. As you can see, everything we do is supported and driven by our members. Advocacy work is always going on. We've had some big wins over the past few years, but there's still a lot of work to be done. I invite you to engage. Let us know if you have any idea or for a piece of legislation. Off the cuff, I love what you said, Dr. Klemmedson, about mental health. You know, the ODA's worked hard to partner with the Medical Association in our state to become eligible to take part in our state wellness program, which provides our dentists hours with a therapist that is not documented or recorded to health insurances, which has been huge. And it was something we really plugged for, and we're able to partner with people to get that funded for dentists. So that, I love that you said that. Also, we'll try and get you a Blackview Porter when we come to Vegas. That's all I have, so feel free to open it up.
Dr. Roa, thank you so much for being here tonight and sharing your thoughts with us. Dr. O'Loughlin, I realize that you're not going to be with us all night for the question and answer portion, but I see you scrolling the chat, and I imagine that you have something to say or some answers or maybe some observations about some of the questions that you see. Go ahead, take it away.
Sure. Well, one question is, why aren't we suing a dental benefit company? Well, in fact, we are. On November 26th in 2019, we entered into a class action suit against Delta Dental Plans Association and its 39 member plans. The basis for that class action suit was the carving up of the national market in a way that would allow benefit plans to reduce compensation in a way that would be harmful to dental practitioners and their practices and create economic instability in their practices. Now, COVID kind of set us back on our heels and slowed down the courts. That case will wind its way through the courts over the next 3 to 5 years. And that's just the way class action lawsuits go. But if we prevail, that could be a major disruption to a significant market dominator across the country. So stay tuned on that. Another question was regarding amalgam, and I can tell you we're right in the middle of the FDI meeting, which is the global dental organization, Federation Dentaire International, and the pressure on the dental profession to reduce and eliminate the use of amalgam is significant. And it's mostly the result of a very sad event that happened in Minamata, Japan, where excessive amounts of mercury in the water supply created enormous numbers of children with significant birth defects, horrible birth defects because of the excessive amounts of mercury and other metals in their water supply. So there has been a WHO initiative where the EPA in the, not the Food and Drug Administration so much, but the Environmental Protection Group has been very active in working on a global treaty, the Minamata Convention, to stimulate a global worldwide reduction in the use of mercury. And dental got sucked into that conversation many years ago, and ADA is not able to directly participate. We work through the State Department and the Environmental Protection Agency and FDI because they have a direct route to WHO. Europe has put enormous pressure on the elimination of amalgam, and many European nations have now banned the use of amalgam completely. We are still fighting the fight, and Dr. Klemmedson was in on these discussions this week, to do a gradual wind down, to look for better, more effective preventive modalities, to research self-healing, non-mercury containing restorative materials that have the utility and ease of placement of amalgam, which is tried and true and lasts for years. It is somewhat bacteriostatic. Many developing nations rely on amalgam to deliver care to people in access poor areas. So stay tuned. The Food and Drug Administration, like all government agencies, I think bowed to the will of EPA and the State Department to put out a pronouncement this year that amalgam usage for pregnant women and children should be reduced or potentially halted. We countered back, show us the science. They openly admitted they didn't have the evidence. And I think this was more of a political move than anything based on scientific evidence. But it's certainly a hot topic, and ADA is, I think, on the side of fighting to maintain the use of amalgam when it's appropriate, where it's appropriate, and stimulate the discovery of better, newer materials that are not so technique sensitive as the current composite family of materials that we use. Dan, do you have anything to add about that? It's a very hot topic globally.
No, I think you covered it very well. We have a EPA problem, and we have a wind down problem by dentists. But Minamata is EPA, and it's not healthcare related. We just are dragged in. If we could get a product that worked as well in the same types of situations where you can utilize amalgam right now at a cost where you can utilize right now, then I think we would be much more inclined to accelerate the wind down. Clearly, we have signed on to a wind down. We just don't want it to end right now because the alternatives, unfortunately, don't exist. And our efforts relative to prevention just haven't ramped up to the point where we don't need that material. We have, unfortunately, the WHO, our ability as a National Dental Association to interact with the WHO is through the State Department or through the FDI. We can't talk to them directly, which is terribly inhibitive. And we need to figure out a way around that, but we just haven't been able to do that.
Thanks, Dan. The other issue that is complicated to explain is a question in the chat about why does the ADA keep credentialing more dental schools? Well, in fact, the ADA is the host of a commission, and the commission has been deemed the authority to accredit dental education programs in hygiene, assisting, laboratory, and predoctoral and graduate programs. It has its own governance. ADA has a corporate veil that protects the commission from interference by the ADA in their decision-making. And according to the Federal Trade Commission and the Department of Education at the federal level, no one has the authority to say no to a dental education program that seeks to open. Every program is expected to submit an application and meet the criteria for accreditation, and it can't be politically influenced. And the Department of Education protects that autonomy fiercely. I can tell you when they think there's undue political influence on the accreditation process, we usually get visited by a few Federal Trade Commission attorneys who like to sit and observe the Commission on Dental Accreditation process. ADA has 4 commissions. They all operate with governance autonomy, and it's because someone else has deemed them the authority to make their decisions. So we have a commission on high stakes testing. It's called the Joint Commission, and congratulations to Oregon for adopting the OSCE. We are thrilled that there is now a very reliable alternative to a live patient exam. We expected that to be much slower in launch, but COVID accelerated that launch. And so congratulations on that move. It's a terrific step to protect the public. The other commission we have is on specialty recognition, and that is to remove the recognition of specialties away from the political process in the House of Delegates and have it determined by experts based on very specific criteria that the House sets. And then the last commission, which I'm sure you know about because you provide continuing education, is the Continuing Education Provider Program, CSERP, and that is to remove any taint of advertising, sales jobs from legitimate dental CE to maintain the quality of that continuing education so dentists can trust it as a reliable source of evidence-based research and science. So I'm going to turn over one question, I think, back to Dan and Michael, maybe. Let's talk about the vaccine mandates that are circulating around the country. Dan, I knew you'd love this one. And Mike, why don't you give a few minutes on this as well?
Boy, I don't know where to start. What I've discovered after a year is that there are a lot of people who don't think like me. My philosophy is the sooner we get this pandemic over with, the sooner we're back to normal. The most likely scenario to get back to normal is vaccines and masks. Unfortunately, there's a lot of people out there that don't believe like us. Many of you may know that some medical organizations came out, perhaps even a month and a half ago, with a recommendation that all healthcare providers be mandated to be vaccinated. We got questioned as to why we didn't sign on to that. In reality, we never got asked, which is a little bit unusual because typically we get asked by all healthcare organizations to sign on. At that point in time, believe it or not, I took it to the board and said, hey, what do you guys think about this? Unfortunately, this year, many times I've been shut down, and the board did not feel it was wise to create a mandate because many people don't like a mandate. One of the reasons why I took it to the board was because I'd have been approached by some dentists when I was at the New York State Dental Association meeting that said, hey, I'm the owner of a large group practice. I want to require that all my employees and dentists are vaccinated. But if I do that on my own, I've got dentists and I've got employees that will leave and go down the street to another dentist. And so we need to have something that's national so that incentive is removed. And despite that, we had the same problem with the national incentive. There is a significant number of people who will just rather quit their job than acquiesce to what for many of us seems natural and normal. And so we have continued and persistently urged, using all the best scientific data, to have all dentists and their entire teams and their families vaccinated. But that's as far as at least the leadership at the ADA, in terms of the Board of Trustees, is willing to go.
And the only thing that I would add is this is pretty much of a political football. So if the Biden administration wants a national program for everybody to get vaccinated and tries to put that in place, the next day the courts are going to be looking at that mandate. And we're seeing a number of governors and a number of states pushing back. So this has become really it's a state issue. And even within the state, as you probably have read, there are, when a governor says we will not do a mandate in the state, that you actually have localities pushing back. And this is true for masks as well. So this is very complicated and all over the board. I would say it's even comical to some extent, but I won't do that because this is really a serious subject for so many of us. But it is really all over the place.
Well, the good news is we have a very high percentage of dentists who are self-reporting that they are vaccinated or will be vaccinated. We don't have reliable data on dental team members, and it seems as though every practice is making their own decision. But we do recommend that dental practices remain in compliance with their state mandates. For example, I think Maine has passed a mandate. I think Oregon, I think, is on the verge, if you haven't done it already. Some of the Californian cities are issuing mandates. So I think we have to be patient and continually educate people on the value of vaccination. The scientific data is in, it really can't be debated. I mean, I think if you are reading the literature at all, you know the vast numbers of people being hospitalized with serious COVID, the vast majority of them are unvaccinated individuals. So we'll keep looking at the science and then, informing you all. I think the power of a tripartite is what you do at the component level, what you do at the state level, and what you do with us at the federal level. And that three levels is an incredibly powerful machine to, as Dan's presentation was titled, we've got your back. And I would hate to think what dentistry would have done without all three actively engaged during the COVID crisis and what could have potentially happened to the profession. So I think there's one or two other questions. Dan, I'm going to give this over to you because it's regarding diversity in leadership and inclusiveness. And there's a question in here about what about consolidation of practices? Is the ADA moving away from recommending solo practice and moving in the direction of supporting the formation of large group practices? And that's another topic we talk a lot about at the Tripartite.
Well, I think that from our perspective, our goal is to support all dentist members. If you're in public health, or if you're in the military, or if you're in the Indian Health Service, or you're in private practice, small group practice, large group practice, or you're an employed dentist and you're a member, we should support you. Clearly, practice models are changing for a variety of reasons, but I think macroeconomic issues are certainly driving much of it. Personal issues are driving part of it as well. Some people just don't want to do what I did, which was own my own practice for 35 years and deal with that. Regardless of the practice model that a dentist decides to participate in, one, they deserve support, and two, they can still, and we expect them to, take care of patients the way that we expect that I take care of patients or you take care of patients. And so the practice model theoretically should not be detrimental to any of the ethics that we aspire to or anything else. If one looks at medicine, there's been phenomenal consolidation. That consolidation has predominantly followed macroeconomic drivers. And I expect that to happen in the dental market as well. If one thinks about it on an individual basis, if a dentist in a small practice or if a dentist has to touch every patient that walks in the door, then ultimate revenues are limited by two things. One, the number of patients you can see, and two, the price that you can get your patients to want to buy your services for. And at some point in time, you can't make that work out from a math perspective. And so we need to at least intelligently evaluate models of practice that allow us to maintain our ability as the leader of the team to see patients, make appropriate diagnoses, make appropriate treatment plans, and make sure outcomes are as good as I would expect of myself. And that's a difficult thought process for people who've been in a solo practice for 40 years, trying to make that jump. It obviously can be done, but it's a difficult scenario. The large group practices do it because they have economies of scale and they have lots of bodies and they have a lot of abilities to negotiate. And so, we have to be brave enough to kind of expand the envelope a little bit within the context of what we deem as appropriate oral health care. Difficult, very difficult.
Thanks, Dan.
Dr. Klemmedson, I have another question that it's a little bit tangential to that one, but it also involves, diversity and inclusion. And this is a question from a new dentist, and it says, you spoke earlier about you were learning something from the younger generation, the new practitioners, and in the same way, our more experienced practitioners have mentorship and sage advice to give to us. So two-part question. One is, what's the importance of age diversity among our leaders and at what levels? And the second question is, what is something that you have learned that's impacted you from a younger practitioner?
Well, I've got lots of young practitioners, and they're much more likely to take a few risks relative to trying some things that I might be more hesitant to. At the board level, we've always had involvement of the new dentist committee, and the chair of the new dentist committee kind of sits at our board table. We're trying to give them a vote in the 14th district, and so I'm pretty close to you guys. I'm in Arizona, but I have a lot of Western states. When I was trustee, everything I could do to get somebody young and diverse at the board was important. Think about it this. I can coast to the end. There are probably people listening on this phone call or on this Zoom call that have a 20 or 30-year timeline. We need to be thinking as an organization 10, 15, 20 years ahead. And so the people who are more engaged in making those decisions and thinking about that are the people who have that timeline ahead of them, not me. And so I always sit there and go, this worked for me, but in the context with which you've been raised and where you're at in your life, how do you see this as working? It's an interesting perspective, but you got to ask the question, and you can't ask the question of another old guy. You got to ask the question of somebody younger, living in the time, and that's not me.
Jeremy, I know we're coming up on the hour, and I wanted Mike to comment on what we're trying to do at the federal level on student debt, which is a contributing factor to the growing number of dentists who are choosing employment right out of school. And we know more women are entering the multi-state large group practice environment as well. So Mike, can you just quickly summarize, and then I'll turn it back over to Jeremy, because I think we're coming up on the hour.
It'd be difficult for me to do. I actually wanted to take two questions at one time. One is, what have we learned from the new dentists? And the board had the wisdom a few years ago to invite new dentists and dental students to our lobby day. We now do a fly-in that runs somewhere around 1,100 dentists, dental students, and new dentists that come in to Washington, D.C. every year, usually in the springtime, where we have a chance to lobby. And it's usually 3 issues. And one of those issues is always a new dentist or usually a student debt issue. So we've learned this. We've learned having the new dentists and the dental students there on lobby day makes this event so much better. Their perspective is what Congress wants to hear. They don't want to hear the more seasoned dentist. They want to hear from the new dentist, the future. They want to hear from the dental students. And we always have an issue around student debt or student loans. Now, having said that, this is a massively complicated issue for Congress to wrap their arms around. We thought with a Democratic White House, House and Senate, that we would actually see some movement, maybe for the first time. Republicans tend not to like to give out money in this way. They feel that you took the loans out, so you must know what you're doing, so you'll pay them back. And unfortunately, dentists tend to be successful. And 98% of dentists pay back their student loans. At least that's the last figure I saw. So with those things going against us, if you will, this has been a tough nut for us. But we have any one of a number of issues that we're lobbying at any one time. Now, one of the more interesting things is there's going to be a report brought to this House of Delegates on student loan, the student debt issue. And the whole idea of this report is to think outside the box. And we're looking forward to presenting that report at the House of Delegates and maybe beginning some initiatives to help new dentists and dental students manage their loans and their debt. So we look forward to that and maybe getting some innovative programs started. That's as quickly as I could do, Kathy.
Kathy, if I might say something, we had a task force that was created by the 2020 House or 2021 House, 2019 House, to look at this one more time. I had 3 new dentists, a dental student, an educator, and a more seasoned dentist on that. They did all the research and everything that the ADA has done, all the loan programs, all the government programs. And to be honest, they couldn't come up with something that was unique out of the box and that would work to dramatically change things. We have limited ability to influence dental schools relative to what they charge people for tuition. Okay, we have some influence over loan repayment. We push loan forgiveness in certain areas, but there's not enough of that. And if we could create more, that is something that's tangible that could potentially help with the people who want to take advantage of it. I've always thought the one thing that we can do, it's not predictable, but what we should be doing is make sure that the abilities of new dentists or any dentist to make a reasonable living, in other words, to get reimbursed correctly and get paid correctly so that they can manage their student debt and their loan service, is probably the most tangible thing we could possibly do. But we know how difficult that is because we're fighting against third-party payers in the US government. So this is a phenomenally difficult program.
I think we're approaching just the very end of our program. Mike, Dr. Laughlin, and Dr. Klemmedson, are there any last observations that you have, anything else that we didn't address that you'd like to address, or any parting words from either the younger or the more seasoned dentists on this call?
Well, what I would say is the following: based upon the questions that you're asking, they're the same questions that we all ask, and those are the questions that we need to keep asking, and we need to keep asking of our leaders, and we need to keep asking of our legislators, and we need to keep pushing. I wish there were simple answers, but they're the same ones. They bother us all, and for myself, who is still working in the trenches just like you, I ask the exact same questions and I have the same frustrations, but we all have to fight together. We have probably one of the best teams in Washington, D.C. that we possibly can, and they support the states phenomenally well. But this is a big tug of war between us, between third-party payers, between the U.S. government, and between our patients. And this is, it's been that way for 160 years. It's not going to go away, and we just have to keep fighting every day. And that's the value of membership, and that's the value of organization. None of us can do it alone. We have a much better chance, albeit frustrating, as a group.
Mike, Dr. Laughlin?
The only thing I would add is that, we've put together programs for refinancing debt. Laurel Road is a good example. We're continuing to look at expanding the dentist buying power through programs through Member Advantage. And we approved 5 new products this year, which set a record for us. And the newest model we're sending out now is ADAPT, ADA Practice Transition. So I would encourage you to go into the ADA website and check out ADAPT. It's a company focusing on career transitions, pretty much from when you are in dental school, transitioning to that first job, finding a mentor, finding a practice to buy, finding a buyer for your practice. And it's scaling rapidly now. It was launched a year and a half ago, and we've just gone national. So keep an eye on that. And it's a digital solution. It's like eHarmony for dentists with a marriage counselor. So pay attention to that program. You'll like it. Jeremy's laughing.
That was very descriptive. Thank you. Mike,
If I might, Let me just say that one of the, I think the best programs that we started was just a few years ago when we created what we call the Power of Three. And this is where there's the synergy between the ADA, our state dental societies, and our local dental societies. And when we're aligned, there's nobody that can stop us, nobody. And we saw that with COVID. If you like getting the PPP loan, if you like getting the provider leave funding, if you like getting the masks and the gowns, and that's just a few things, it was because we as a profession hung together. When we separate, we're going to get lost. We're going to get lost on Capitol Hill. We're going to get lost in the state capitol. And you know, it's never turns out well for dentistry. So the Power of Three works. Let's all work together for the good of the profession, your practices, and your patients.
Mm-hmm. Thank you to all our attendees, Dr. Klemmedson, Dr. O'Loughlin, Dr. Roa, and you, Mike, as well. We so appreciated you being here today. One more recognition today is all of the staff that helped put this together. It's no accident when all these people come together on a call. So thank you for making it happen, and for our panelists to let us know what's going on. And one more thank you to Dr. Fred Bremner. Typically, our component sits around and we talk about how do we do a celebration and pat ourselves on the back and go do something fun and eat and have a good time. And with COVID, he said, why don't we do something for the good of the rest of the state? And through his idea, this came to light. So no better way to highlight the recent recipient of the Tom Tucker Humanitarian Award than this is what he plans and does with his time. So a big thank you to Dr. Bremner. With that, thank you to all our attendees and have a great night.